Hi and welcome. My name is Sara Beattie. I'm a clinical psychologist at the Tom Baker Cancer Center in Calgary, Alberta. I work specifically with individuals who are going through stem cell transplants, as well as their support people and also those who are diagnosed with blood cancers. Today, as part of the BMT101 series, I'm going to be talking to you about psychosocial considerations in stem cell transplantation. So the learning objectives today are firstly to recognize the psychosocial challenges for patients during transplant, as well as then recognize the psychosocial experience of caregivers during the transplant trajectory. And lastly, I'm going to discuss the role of the psychosocial oncology clinician in stem cell transplant. So I'm going to start off by talking about psychosocial risk factors and challenges. And one of the reasons that this is really important is that the most frequently reported unmet needs in allotransplant patients, in fact, are psychosocial, as according to the research. So at the Tom Baker Cancer Center, as part of our BMT standard practice manual, we reviewed the literature on patient variables for assessing transplant eligibility. You can see that in the link below, and we have since published this. I'm just going to focus briefly on the psychosocial variables and briefly review them. So this is more for that pre-transplant period, but some of the psychosocial variables to take into consideration are distress, because it is associated with post-traumatic stress disorder. And it can include uncertainty, concerns around appearance, sexuality and health, as well as burden associated with post-traumatic stress. Distress has not been found to be related to survival, and there are strategies such as CBT and emotional processing methods that might provide benefit to alleviate this distress. Another psychological variable is depression, and we do see that about 12% and up to 30% of people experience depression at 5 years post. Pre-transplant depression has been found to be related with lower overall survival and higher acute graft versus host disease. So again, highlighting that importance of seeking psychosocial support prior to transplant. Anxiety is another factor, and often it's found to be highest pre-transplant. And then non-compliance, that's another important psychological variable. The prevalence is unknown, with someone citing up to 80%. Again, that could be compliance in different ways, but risk factors that have been found in the literature are being male, having depression, higher distress, increased nausea and vomiting severity. And it's not clearly predictive of post-transplant outcomes, and this possibly could be because the prevalence is unknown. It has been suggested that the following considerations may improve compliance. So provision of clear and consistent information with specific information on why consistent compliance is beneficial, simplifying treatment so that it can be easy to follow, prioritizing environmental precautions and health behaviors, suggesting ways to assist with forgetfulness, and tailoring the regimen as much as possible to the lifestyle of the patient, so trying to be very patient-centered. Other psychological variables include substance abuse. There's unclear correlation with post-transplant outcomes. Psychological functioning and coping styles, it's interesting, it seems so important, yet there's no data on that. Financial status and socioeconomic status. Lower SES has been associated with poor overall survival. GVHD, the relationship with that is less clear. Lower education is associated with higher distress. Lower income has been associated with higher distress and poorer physical functioning. And then lack of employment has also been associated with worse physical functioning. Lastly, caregiver considerations, which we'll go into a bit more. Increasing reliance and consistent caregivers have actually been associated with improved overall survival. So these are all pretty important factors. And how do we integrate this into kind of our pre-transplant assessments? One of the conclusions we came to was that psychosocial factors do not represent an absolute contraindication to transplant. So a lack of safety data for patients who exhibit severe psychiatric illness, such as major depression, suicidal ideation, or high intent, psychotic illness with delusions or hallucinations, etc., active alcohol or drug abuse, or those who demonstrate profound degrees of non-compliance. This may be a consideration, but again, it's not an absolute contraindication. Again, early referral, ideally at diagnosis of malignancy to psychology, social worker, psychiatry is appropriate for those with those higher risk factors, could really benefit both from a psychological as well as a physical standpoint. And then the one thing is that transplant may not be offered in order to prioritize patient safety. So non-engagement and compliance with psychosocial services or if psychosocial concerns are not able to be stabilized might be a reason, especially when those psychosocial factors severely impair functioning and or adherence to treatment plans, or maybe they potentially place the patient at immediate safety risk. This would be people who are, say, actively psychotic or high suicidality, substance dependence, maybe even with extreme poverty or high degree of family conflict. So these are important considerations pre-transplant. Now looking at psychological functioning more over the transplant trajectory. So distress has been defined as a multifactorial, unpleasant, emotional experience of psychological, so that could include cognitive, behavioral, and emotional, as well as social and or spiritual nature that might interfere with the ability to cope effectively with cancer, its physical symptoms, and treatment. So distress really does extend along a continuum ranging from common normal feelings of vulnerability, sadness, and fears to problems that can become disabling. What we have seen in the literature, it's highest pre-transplant, 35 to 40% versus approximately 30% in the general oncology population, and can range anywhere from 5 to 50% across the transplant trajectory. Clinically meaningful distress is elevated in 22 to 43% of long-term survivors. And depression and anxiety has been reported in about 12 to 30% of survivors, but it's really hard to there's been so many different prevalence rates. There has been actually a study that showed up to 44% of patients had a prevalence rate of a psychiatric disorder, but then as low as kind of around 12%. And one of the things we see is that while emotional distress does not always reach the level of kind of clinical depression, clinical anxiety, or an adjustment disorder or post-traumatic stress, it really can have the potential to impact quality of life and cause that prolonged distress. So we don't need to necessarily have individuals reach a clinical level to require additional supports. Post-traumatic stress disorder, just a few quick words on that. So post-traumatic stress symptoms are characterized by reliving of traumatic events, avoidance of trauma-related reminders, and hypervigilance and heightened arousal. We know that as many as 80% of cancer patients experience some post-traumatic stress symptoms, and up to 1/3 may experience post-traumatic stress disorder. That's according to the National Cancer Institute. The incidence of probable PTSD in transplant survivors, interestingly, they say it ranges from 3 to 13%. Again, the prevalence rates aren't clearly defined, but we typically do see a decline in intrusive thoughts and avoidance symptoms over the first year. Correlates of post-traumatic stress symptoms in transplant are a history of previous psychological concerns, current psychological distress, reduced physical functioning, lower social support, increased social conflict, as well as greater use of avoidance coping and negative events. So switching gears to kind of neurocognitive functioning, another important concern. So cognitive impairments have been detected, again, according to self-report, in 40 to 60% of adult survivors. Patients do report more problems than by objective testing, which is possible There could be so many reasons for that. One is also that objective testing doesn't typically, people have not had any kind of neuropsych evaluation prior to transplant or their diagnoses, so it's hard to know what their baseline was. What we do see is that many recover cognitive function within a year, but some mild impairments do remain evident for 5 years post-transplant. Some risk factors include being young, being female, and having an absence of a social partner. Any pre-transplant memory problems is also a risk factor. Getting TBI or a history of cranial irradiation, as well as IT chemo. Chronic graft versus host and chronic immunosuppressive therapy also are risk factors, as well as length of stay and having a lower SES. So speaking of social and financial challenges, some challenges that are cited are difficulty with social reintegration, difficulty with social support, as well as difficulty with role changes and the multiple role changes that sometimes occur. One of the challenges is there is a lack of well-validated instruments to measure social and financial outcomes. So their use of mostly small institutional studies and the absence of longitudinal data are some of the kind of gaps in research for this complication of transplant. Nonetheless, the prevalence of financial hardship in the research right now ranges from anywhere from 20 to 70%. Again, this isn't in a Canadian sample, just generally. And in terms of return to work, which is also a challenge, one of the studies said that about half of allo patients had returned to work at approximately 2 years post-transplant. And they found that chronic graft versus host was a contributing factor, as well as lower physical functioning, being female, being the recipient of peripheral blood stem cells for an unrelated transplant. All of those are associated with a lower likelihood of return to work. It's also suggested that kind of a lack of standard guidelines in the transplant world and within clinicians has been one of the potential causes of this, because of not having those standard guidelines. It makes it hard to have consistent communication about return to work and expectations around that. So looking at kind of risk factors for psychological morbidity, trying to put all of this a bit into context. This diagram provides a compilation of psychological morbidities risks identified from the literature regarding transplant patients. Again, because these risks have been identified in studies using varied transplant populations, small sample sizes, and various questionnaires and methodologies, it's impossible to quantify the effects of each factor on psychological morbidity or the relationship between the factors, but it kind of represents a good step in the process of risk identification. So I'm going to go a bit more into each just to make it a little clearer. So when we think of individual risk factors, that could be things such as previous psychiatric morbidity, compliance issues pre-transplant, being an adolescent or young adult, female sex, avoidant coping strategies as opposed to more active coping strategies, recent smoking cessation, lower functional status upon admission, as well as lower income. Exogenous factors would be kind of challenges with presence or quality, or even the perception of social support. Presence of difficult or conflictual relationships, as well as more challenges with professional reintegration concerns. And then if we look at transplant-related factors, that might be persistent symptoms such as chronic pain and fatigue, as well as potential increased regimen-related toxicity, slower physical recovery, chronic graft versus host disease, immunosuppression, having a negative appraisal of the transplant experience, higher body image disturbance, heightened fears of recurrence or secondary malignancies, and sexual function disruption. So those are more the psychological morbidity factors, but I also do like to mention that we do sometimes see some positive psychological outcomes as well, and this will be something that we discuss with patients as well, but some people do talk about post-traumatic growth, which is a positive psychological change experienced as a result of exposure to traumatic or highly challenging events. So some things that people will cite are enhanced appreciation of life, improved relationships, existential growth, increased self-confidence or self-esteem, and some transplant survivors report emotional growth beyond their pre-transplant levels. What are some factors that do predict that post-traumatic growth? Being a female, being younger, and having higher levels of social support, higher levels of spirituality, and increased resilience. So speaking of personal resilience, people who have greater personal resilience resources also predicted decreases in post-traumatic stress symptoms. And this was mediated by reductions in depressive symptoms and in searching for kind of a reason for one's illness. Those greater personal resilience resources also predicted increase in purpose in life, and that was mediated by reduction in depressive symptoms. So having greater personal resilience resources may promote better psychological adjustment by improvement in depressive symptoms and decreased use of potentially maladaptive forms of meaning making. So this is important too, because these are things that we can help support people with, is increasing resilience. So as we switch gears and we're going to take a look at some of the caregiver challenges, I always just like to mention, I think we all appreciate why caregivers are important, and we do very much ask a lot of people support people. And by caregivers in this, I do mean informal caregivers, the loved ones, the family members, the friends that may be helping support people during their transplant process. So I always do like to mention, what the literature has said on social support and survival. And it's quite interesting if you look at these survival graphs. So firstly, the consistent presence of a caregiver during hospitalization for an allogeneic transplant was found to predict longer 5-year survival rates. And this was controlling for severity of the disease and presence of graft versus host compared to patients who had a consistent caregiver during hospitalization. Patients who did not have such a caregiver were 3 times more likely to have passed away at 5 years. And you might wonder if it's related to instrumental support only, so such as like compliance, calling more, those things. But this follow-up study found not only that the overall survival improved, that relapse-free survival improved. So it suggests that the impact of caregiving does go beyond that, and perhaps there's a direct or indirect biological effect we don't appreciate or understand yet. Interestingly, the quality of support offered by caregivers may in fact influence survivors' survival as well. So in another study, patients whose caregivers were most critical and pessimistic had 3 times the mortality risk at 4 years. This being said, while this is really interesting data, more recently, along with Dr. Tay and colleagues at CEI BMTR, we did look at marital status as declared pre-transplant. So we use this as a surrogate marker. And so there are definite limitations to this, a surrogate marker for social support, and it was not correlated with survival. But again, the limitations are it was just a large database with one time point using that as a surrogate, but it was associated with chronic GVHD. So the relationship between social support and survival, it's complex, and further research is needed to better understand this relationship and what elements of social support might be the most beneficial, both for psychological as well as survival outcomes. Is it informational, just that advice, getting info from the team? Is it instrumental, more those tangible, practical things, or is it the emotional parts of social support? So switching gears to the psychosocial needs of caregivers, I always just like to mention that, caregivers take on so many roles, and highlight this because, again, we do, as a medical team, really rely on caregivers, those informal caregivers, to contribute a lot to the patient's medical journey. So I'm just going to highlight some parts of this, but some pieces of the experience of caregivers are just the distress, the needs, the burden, how they function as dyads, what the benefits may be, and then the long-term effects. But again, I'm only going to focus on a few of these today. So what do we know about caregiver distress? Similarly to patients, it's highest pre-transplant and then it decreases over the trajectory. Importantly, caregivers themselves may experience more distress than the transplant patients, and they compared to both patients as well as controls, caregivers reported more loneliness and lower levels of perceived support. Predictors of caregiver distress include being female, having a higher level of subjective burden, patient symptom distress, and stage of life. So, you know, if they had competing demands, say they had a young family. Caregiver burden. So there has been limited studies on burden like in the longer term. Most have focused more on that pre-transplant and 30 days post, but it is clear that caregivers do experience a high level of burden, and it's often thought to have both an objective and a subjective component. So objective burden is that tangible events associated with caregiving, such as diminished time for personal activities. So here they shared that time and financial commitments and decreased energy were the biggest pieces. And subjective burden consists of the feelings such as guilt and fear accompanying the caregiver experience. And here we can see that caregivers said it was difficult to watch their relatives suffer and challenges with uncertainty about the future. Caregivers do try to learn to balance the needs of the patient, their own needs, and that of the relationship, as well as any other competing demands. Importantly, caregiver burden is also related to perceived inequity. So if it feels like the relationship is not equal, both from an emotional and a kind of more practical standpoint, as perceived by either the patient or the caregiver. And then burden also appears to be a key variable in caregivers' experience of distress. So with higher levels of burden contributing to higher levels of distress. So what are the needs of caregivers? There are psychological needs, including the fears of the future, challenges with coping, finding it difficult to watch their relatives suffer, as well as those uncertainties. The practical needs, they cite patient care needs as one of the biggest ones. Ability to communicate with the healthcare team, time and financial commitments, those competing demands, as well as decreased energy. Social needs, difficulty adapting to role changes, changes in relationship with the patient, lack of time for themselves and leisure activities, as well as managing communication with families and friends. I always think that this needs of caregivers and those identified most difficult activities is interesting, because often I think people will assume it's more those instrumental, the more medical-based ones, but here the top ones are clearly more those emotional ones. So that listening when the patient was feeling very sad or scared, listening to concerns, helping with the emotional ups and downs, just really highlighting that those emotional supports often are the hardest for caregivers. And then what about patients and caregivers as dyads? So this is specifically for, this research is looking at people in relationships. But what we see is that caregiver marital satisfaction was significantly lower than patient marital satisfaction 6 months and 1 year post-transplant. And we see that female caregivers experience more distress and lower satisfaction. We also see caregivers hide their own fears and worries related to cancer and the transplant in an attempt not to cause any added distress to the patient. And interestingly, perceived relationship quality at 6 months and 1 year post-transplant may positively impact the patient's mental and physical quality of life. So knowing that interventions to support the relationship may help both from a relational standpoint, but also may really benefit the patient's mental and physical health. Again, wanting to make sure that we do reflect on some of those benefits of the caregiving role, we'll see that personal growth has been identified, so gaining new insights and appreciation of life, being better able to prioritize activities and goals, developing new and potentially positive coping strategies in dealing with that lack of control, uncertainty, and loss. Improvement of relationships, increased ability to express needs. People have also said improved relationships specifically with the transplant recipient, and increased perception of rewards was associated with being of younger age, and increased preparedness for the caregiving role, which also kind of leads to that idea of how, as a team, can we better help prepare caregivers for that role. And maybe transitions nicely to just briefly to touch on, what is the role of the psychosocial oncology clinician, depending on what you have access to at your site, but often I'll see it as maximizing the function of patient, family, and the medical team. We're able to do both assessments and therapy within our site. And just some thoughts about, kind of how we all work together and how we do some psychosocial screening and assessments. So kind of in accordance with cancer care guidelines to screen for emotional distress by the National Comprehensive Cancer Network in 2016, we at the Tom Baker had adapted the screening for distress tool, which for us was the ESAS and the Canadian Problems Checklist, and have routinely administered it within our transplant program. It's actually switched names to being now called the Putting Patients First, but it is intended to facilitate conversations with the patient, to understand these concerns, and then also to help other team members make appropriate referrals and to psychosocial and other specialized services. So that kind of routine screening of distress. One of the things that's challenging is how often do we screen for it? Is it at every clinic visit, or do we follow those recommendations to screen for psychosocial challenges post-transplant, say 6 months, 1 year, 2 years post, or just when we feel it's needed? Also, what are each center doing in terms of pre-transplant psychosocial assessments? So we did find that most, along with some colleagues, we've recently done an environmental scan that we will hopefully be submitting for publication in the next few months. And we looked at all the Canadian centers, and what we found is that most centers are doing some form of screening. However, each center does have different resources, and they also have a lack of standardization of assessment and psychosocial clinician or resources available. One of the things our center has recently done is develop a pre-transplant psychosocial kind of education class where we introduce ourselves, try to help with that preparation and coping for patients and caregivers, as well as make the resources seem more accessible, as well as the team. But because of lack of standardization, it's hard to evaluate how this may be versus other approaches. So it's all very interesting, and I think lots of future work can be done there, and it's very important to continue to kind of know what resources are available at your site. So thank you for your time today. In summary, both patients and their support people may experience heightened distress during the transplant trajectory. Knowing local resources and when to refer to psychosocial clinicians is paramount in supporting patients and caregivers. Please note, in my BMT101 series for patients and caregivers, that does include some coping strategies as well as resources for self-management that may be of interest as well. Thank you very much.